Dr. Rajendra Aparasu from Houston University. He's a visiting scholar, Fulbright scholar, visiting us for teaching and research in pharmacy. So his background is pharmacy administration and policy. And then he came here by the Aminef and Fulbright Indonesia. So thank you very much also for Aminef and Fulbright Indonesia. And then Lua Potier, she is graduate student from London Hygiene, the name is very difficult, London School of Hygiene and Tropical Medicine. And she is currently doing a research in Indonesia with BPJS Lapor. So I guess that all of our guests and participants here also related to health sciences and data especially. So thank you very much for coming. And to introduce this Brownbag Discussion, a special edition. Brownbag Discussion is a regular meeting of IPP, Institute for Public Policy, Atma Jaya Institute of Public Policy. So we have regular meeting at least once in 2 months, and today will be very special one because we have an open discussion so that all of us may know and understand how we can get policy starting from health data. And then by that, we hope that the result of this meeting may also be productive for all of us to analyze data and aware of the health data. So another thing that I want to introduce also that Ibu Nafsiah is part of the her great contribution to us is Ben and Nafsiah Mboi collection. So Pak Ben Boys and Ibu Nafsiah's personal libraries then was dedicated to Atma Jaya and be part of Atma Jaya library. So I invited all of you to visit the second floor of Atma Jaya library where Ben and Nafsiah Mboi collection was reside. So it's very beautiful collection, 23,000 books and documents, and most of them related to policy. The field where Ibu Nafsiah and Pak Ben Boy very master at. So without further ado, have a very nice and fruitful discussion, and thank you very much. Thank you.
Oke, mungkin selamat siang. Saya akan memperkenalkan diri dulu. Saya moderator untuk hari ini. Nama saya Yunisa Astiarani dari Fakultas Kedokteran dan Ilmu Kesehatan Atma Jaya. Jadi kita akan membagi sesi ini jadi 3 bagian. Yang pertama pembicaranya Ibu Nafsiah Mboi, kemudian Prof. Raj, dan Lua yang terakhir. Nanti masing-masing sesi akan diawali dengan presentasi oleh masing-masing pembicara selama 20 menit. Dan kita akan ikuti dengan diskusi selama 10 menit. Gitu. Yang pertama mungkin kita serahkan kepada Ibu Nafsiah. Ibu Nafsiah seperti kita tahu, beliau adalah pernah serving sebagai Minister of Health dari 2012 sampai 2014 dan kemudian sekarang aktif sebagai member dari Institute of Health Metrics and Evaluation. Dan beliau akan mempresentasikan tentang using data untuk meningkatkan health policy, experience, dan contoh dari Indonesia. Waktu dan tempat saya persilakan Ibu Nafsiah.
Terima kasih Bu Bet dan Dr. Yuni. Teman-teman sekalian, para hadirin, terima kasih atas kehadirannya. I have done my slides in English, but allow me to present this in Indonesian, and I will be very happy to answer or participate in discussions in any language. Okay? Jadi saya diminta untuk bicara tentang using data, bagaimana memanfaatkan data untuk memperbaiki kebijakan kesehatan. Dan ada 5 pertanyaan yang diajukan oleh panitia kepada saya, memang banyak, tetapi saya sambil jalan akan berusaha untuk menjawabnya. Saya tidak pakai teori, oke? Saya kasih contoh dan dari pengalaman. Karena dalam 50 tahun saya berkecimpung dalam bidang kesehatan, setiap policy yang baik membutuhkan data yang baik. Tetapi pada awal-awal tahun 60-an, kami tidak punya data yang baik. Ya, itu tidak jadi masalah. Kita tetap harus membuat kebijakan, tetapi terus-menerus memonitor kebijakan itu. Baik, untuk mempersingkat waktu, saya akan ngomong tentang 3 hal ini. Bagaimana data di Indonesia dimanfaatkan untuk menyusun kebijakan kesehatan, terutama di sini, sebagaimana diketahui, data ada banyak sekali ya di Indonesia. Kita kaya sekali akan data. Ada yang secara khusus di-collect, berupa survei, riset, dan sebagainya. Ada yang secara rutin dilaporkan, tetapi ada juga yang kita pelajari dari akademisi. Kita ambil dari akademisi. Nah, kali ini saya akan berikan contoh satu sumber data yang baru yang kita pakai selama penyusunan RPJMN 2020-2024. Oke, antara lain. Yang kedua, saya akan ngomong tentang bagaimana RPJMN 2020-2024 itu disusun dengan memanfaatkan berbagai data, tetapi banyak pakai global burden of disease yang saya katakan kita bersyukur di Indonesia oleh karena kebiasaan kita mengumpulkan data, memanfaatkan data, menganalisa data itu sudah dari tahun 60-an. Dan terakhir, karena bagi saya tidak ada gunanya policy kalau tidak ke action. Dan kita tahu bahwa data juga harus meng-guide action supaya action itu efektif dan efisien. Oke? Nah, pertama mari kita ngomong tentang data yang kita pakai di Indonesia, khususnya yang dimanfaatkan untuk RPJMN 2020-2024. Secara khusus di sini saya mungkin teman-teman sudah tahu data yang lain, tetapi khusus saya akan ngomong tentang burden of disease. Burden of disease ini memang dikembangkan oleh Institute of Health Metrics and Evaluation yang sekarang berkedudukan di University of Washington di Seattle, dan itu menghitung atau menganalisa data-data dari 313 penyakit dari 194 negara, penyakit dan 84 risk factors. Oke, dengan memakai ukuran baru. Jadi bukan hanya angka kematian, angka kelahiran, tetapi DALYs, which is disability adjusted life years. Jadi berapa tahun sehat itu hilang karena seseorang sakit atau disabled. Dia tidak bisa bekerja. Oke? Tapi kalau mau tanya lebih detail tentang itu, sesudah pada tanya jawab aja ya. Nah, kita lihat misalnya, ketika kami melihat salah satu, saudara-saudara masih tahu bahwa sejak tahun 2000 sampai 2015, secara global kita berfokus pada Millennium Development Goals, bukan? Dan itu komitmen semua negara anggota WHO termasuk Indonesia. Karena itu, waktu saya jadi Menteri Kesehatan juga, nomor 1 saya punya tugas adalah angka kematian bayi harus turun. Nah, memang ada yang bilang, naik kok Bu. Ternyata waktu kami menilai, maka secara sangat meyakinkan turun. Ini angka kematian di bawah 5 tahun, kita kumpulkan dari 1990 sampai 2017, dan ternyata memang turun sekali. Tetapi Yun, kalau kamu duduk sini lebih enak deh Yun. Thank you. Masih terlalu tinggi, karena itu komitmen kami adalah masih akan dilanjutkan 20 dalam RPJMN berikut. Tetapi kita tahu bahwa pada tahun 2017, 82,4% dari semua angka kematian balita, yaitu ini tambah ini, itu terjadi di bawah usia 1 tahun. Oke. Sedangkan dari semua bayi di bawah 1 tahun yang meninggal, ternyata pada tahun 2017 sebanyak 63,2%. Ya. Sedangkan dari neonatal, jadi yang ini neonatal, itu artinya usia di bawah 40 hari, bukan 1 bulan, itu 81,3% dari kematian neonatal itu terjadi pada 7 hari pertama. Nah, kalau saudara-saudara berminat pada kesehatan masyarakat, maka otomatis mengatakan, oke, di mana masalahnya? Ya kan? Nah, ini yang harus dianalisa, mengapa begitu? Tetapi ternyata, dari data yang banyak ini, dari Subnational Burden of Disease, yang kami lakukan waktu itu dengan biaya dari APBN, ternyata biasanya dikatakan ada ketimpangan, bukan? Itu salah satu challenge kita dalam pembangunan kesehatan di Indonesia, yaitu ketimpangan. Dan biasanya dikatakan ketimpangan antara Indonesia bagian timur dan barat. Kalau kita lihat angka kematian balita, yo-yo, pada tahun 2017 kita temukan bahwa yang terendah adalah di Solo, cuma 11,6 per 1000 kelahiran hidup. Yang tertinggi adalah di Asmat, Indonesia bagian timur, yaitu 89 per 1000 kelahiran hidup. Lalu saya minta bagian teknis, saya mau lihat datanya, mari kita analisa, jangan hanya Indonesia Timur, Indonesia Barat, per pulau. Nah, karena itu kita lihat misalnya di Sumatera, ternyata Kabupaten Lingga itu kematian balitanya 50,1, sedangkan Riau dalam pulau yang sama 14,7. Jadi bedanya 35 tahun. Sedangkan di Papua yang terendah itu adalah Kota Sorong, 19 per 1000 kelahiran hidup, tapi Asmat 89 loh. Berarti kondisi antenatal care, mulai dari kehamilan, persalinan, sampai postnatal care, di kabupaten-kabupaten itu buruk sekali. Jadi di situ kita harus pusatkan perhatian kita supaya capai pemerataan. Dan memang ternyata Presiden Jokowi setuju untuk ke depan pemerataan sangat penting diperhatikan. Oke? Begitu juga kematian ibu. Ya. Jadi di MDGs itu kematian bayi, kematian ibu tuh. Kematian bayi, kami lihat ternyata Indonesia itu prestasinya luar biasa, turunnya luar biasa. Meskipun sebagai Menteri Kesehatan saya dimarahin loh, karena dibilang kematian ibu meningkat. Tetapi kemudian dengan berbagai macam cara baru kita lihat bahwa memang metodenya berbeda ya. Jadi oke, kita lihat dengan satu metode ini bahwa ternyata Indonesia itu prestasinya juga luar biasa. Namun tetap sekali lagi kita masih merasa tidak puas. Ini masih terlalu tinggi. Kalau bisa jangan ada satu ibu yang meninggal karena melahirkan, iya kan? Nah, ini masih terlalu tinggi. Karena itu kita mencari apa penyebabnya. Ternyata penyebab pertama adalah perdarahan pada ibu. Yang kedua adalah tekanan darah tinggi pada ibu. Yang ketiga adalah kelainan ibu yang lain. Ada anemi, ada kelainan jantung, PPOD dan sebagainya. Jadi kondisi ibu hamil yang buruk. Ya. Kemudian yang keempat adalah aborsi atau miscarriage. Dengan adanya itu saya semua data ya, kalian nanti bosan sampai besok kita duduk di sini. Tapi data semua ada dari 313 penyakit dan faktor risiko. Nah, kita lihat bahwa salah satu tolok ukur pembangunan kesehatan adalah life expectancy atau harapan hidup. Nah, kita lihat di sini Indonesia juga hebat loh. Ya. Jadi ini perempuan meningkat terus, begitu juga laki-laki meningkat terus. Walaupun memang masih agak lebih rendah daripada global, yang titik-titik global. Ya, kalau di sini ada angka-angkanya, jadi perempuan tahun 2017 70,48, laki-laki, perempuan 75,59 tahun. Itu harapan hidup. Jadi saya sudah lebih dari harapan hidup perempuan. Oke. Tetapi lalu kami lihat bagi per provinsi. Antara tahun 1990 sampai 2017, apakah semua meningkat? Jawabnya ya. Tapi peningkatannya tidak sama. Dan kita lihat misalnya di sini saya tunjukkan Sumatera Barat bertambah 8,8 tahun. Ya, hampir 30 tahun itu ya. Sedangkan Jawa Tengah meningkat 5,9 tahun. Yang sangat mengherankan, yang di luar perkiraan kami adalah Nusa Tenggara Barat. Meningkatnya 12,2 tahun. Memang dia mulainya paling rendah, angka harapan hidup di Nusa Tenggara Barat, tetapi kemudian dia bisa kejar. Kenapa dia bisa kejar? Oleh karena yang merah ini adalah penyakit menular, masalah ibu dan bayi, dan gizi, kurang gizi. Ternyata Nusa Tenggara Barat bersukses betul dalam penanggulangan penyakit menular, ibu dan bayi dan gizi, dengan mereka punya gerakan satu telur sehari itu, dan ternyata bisa meningkatkan harapan hidup sampai 12,2 tahun. Sedangkan kita punya saudara-saudara di Papua tidak ada kegiatan sama sekali, sehingga angka harapan hidup hanya meningkat 2,7 tahun saja. Jadi kalau saudara jadi Menteri Kesehatan, kamu bikin apa? Hah? Kalau saudara jadi Menteri Kesehatan atau Menteri Keuangan atau jadi Presiden Republik Indonesia, kalian bikin apa? Kita jawab sendiri aja. Nah, kemudian kami lihat, kami tidak puas dengan hanya angka harapan hidup. Buat apa hidup kalau tidak sehat? Karena itu salah satu tolak ukur baru adalah healthy life expectancy. Harapan hidup sehat. Dan kami lihat perbedaan tidak hanya antar daerah. Ini kelihatannya, ini antar daerah perbedaannya cukup banyak ya. Tetapi kita juga perbandingkan antara laki-laki dan perempuan. Dan antara perempuan dengan perempuan, laki-laki dengan. Coba lihat ini perempuan. Perempuan di Sumatera Utara, harapan hidupnya 77,5. Tapi sehat hanya selama 66,7 tahun. Berarti apa? Wanita di Sumatera Utara sebanyak 10,8 tahun dia hidup dalam kesakitan atau penderitaan karena disabilitas. So, saudara pikir, kalau saudara Menteri Kesehatan, saudara bikin apa? Atau saudara jadi gubernur deh? Atau kepala dinas kesehatan paling kurang ya? Oke. Hal lain yang kita lihat adalah adanya transisi epidemiologis. Kita tahu, memang. Tetapi dengan adanya perhitungan burden of disease ini, kita bisa lihat berapa banyak. Misalnya pada peta gambar ini ya, saudara lihat, tahun 1990 yang paling banyak apa? Merah, betul. Yang merah ini adalah communicable diseases, maternal, neonatal, and nutritional. Jadi sebagian besar kematian disebabkan karena penyakit menular, ibu dan anak maupun kurang gizi. Tetapi di sini paling banyak sekarang adalah biru. Biru adalah non-communicable diseases atau penyakit tidak menular. Ya. Nah, sekarang kami periksa lagi kembali. Penyakit apa itu? Dan memang kita lihat kalau bandingkan 1990 dan 2017 bahwa ini ranking 13 penyakit selama 2017 ya. kita lihat ini yang turun, tuberkulosis yang merah, diare, penyakit paru-paru, kemudian neonatal jadi bayi ya, turun. Juga kecelakaan lalu lintas. Tetapi yang lain, yang biru, dan itu adalah penyakit tidak menular, yaitu stroke, dia naik 122%. Penyakit jantung, diabetes, naik 162%. Cirrhosis, ini PPOD, penyakit paru-paru obstruktif kronis. Tetapi ini yang mengkhawatirkan saya, Alzheimer's, naik 237%, dan sebagainya. Jadi kita punya data, per penyakit, per daerah, per provinsi juga kita punya. Supaya kalau antara kalian ada yang jadi Menteri Kesehatan atau Presiden, tahu mau bikin apa. Nah, ini per provinsi. Mana tadi teman itu dari Maluku Utara? Hah? Yang mau ke Maluku Utara tadi siapa? Siapa kan namamu? Samuel. Samuel, kalau kamu lihat, kamu cari Maluku Utara yang ini. Saya di sini aja ya. Ini Maluku Utara. Ya. Maluku Utara, jadi itu nomor 5. Ya, ini Maluku Utara. Dia tinggi sekali kematian karena penyakit menular, penyakit tidak menular, penyakit menular maupun cedera. Jadi kita lihat semua provinsi masih ada penyakit menular. Rankingnya demikian, kita bisa lihat jumlahnya dan di mananya. Oke? Nah, sekarang saya tinggalkan penyakit, saya ke faktor risiko. Di dalam Global Burden of Disease ada 84 faktor risiko yang diperiksa. Dan ini sangat penting. Oleh karena kita tahu kenapa, maka kita bisa intervensi. Karena kita tahu faktor risiko ada 3 macam ya. Metabolik, karena perilaku, atau karena lingkungan. Lingkungan atau termasuk lingkungan kerja, macam pekerjaan. Yang hijau. Nah sekarang lihat aja. Apa faktor risiko yang dihadapi rakyat Indonesia? Nomor 1, 2, 3, 4, kalian sudah tahu. Saya akan fokus khusus pada tembakau, karena ini paling lagi top hit sekarang ya. Nah, kenapa? Pertama, memang saya juga di Komnas Pengendalian Tembakau dan dari dulu selalu perang lawan industri tembakau ya. Kalau yang kenal saya dari dulu. Tapi apa yang kita lihat? Pada laki-laki, ya, antara tahun 1990 dan 2017, semua provinsi prevalensi merokok meningkat semua. Ya, tidak ada satu pun yang tidak. Paling rendah peningkatan adalah Gorontalo 6,2%. Paling tinggi adalah Jawa Barat 17,8%. Tetapi yang bikin sampai Ibu Menteri Keuangan akhirnya setuju usul kami untuk menaikkan cukai rokok dan harga rokok adalah data-data ini. Bahwa pada tahun 2017 68 juta orang Indonesia yang merokok, laki-laki 58%, ya, dan meningkat. Tetapi ini yang paling ini, yaitu waktu RPJMN yang lalu, ya, jadi antara 2013-2018, perokok anak naik dari 7 sampai 9%. Sedangkan perempuan, dan ini lebih mengkhawatirkan, perempuan dalam 5 tahun naik dari 1,3 menjadi 4,8%. Naik 3 kali lipat. Dan kita tahu kalau perempuan merokok, itu dampak pada anak, pada keluarga, pada komunitas. Ya. Nah kalau saudara Menteri Kesehatan, kau bikin apa? Kau terima aja, terima suap dari pabrik rokok, tidak bikin kebijakan apa-apa, atau kau rubah? Dan kita tahu bahwa penggunaan tembakau itu force leading risk factor keempat untuk kematian di Indonesia, tetapi untuk laki-laki leading risk factor nomor 2 loh, sesudah pola makan. ya, dan dia menginikan 24% dari penyakit jantung dan 64% dari lung cancer. Dan ini mahal. Penyakit tidak menular itu mahal. Jadi BPJS defisit, kita marahin BPJS-nya. Kita nggak marahin perokok, ya. Dan ini kalau kita bandingkan laki-laki dan perempuan, yang hijau muda ini berarti dia sendiri merokok. Berarti laki-laki ya memang dia merokok sendiri. Kalau perempuan memang antara dia merokok dengan second hand smoke, itu lebih banyak second hand smoke. Jadi dia jadi apa namanya? Ya, saya harap kalian ada satu hari yang bisa membuat policy dan juga melawan terutama e-cigarettes, vaping. Oke? Nah, bagaimana dengan RPJMN? Jadi prosesnya memang cukup panjang ya, dan saya tidak akan terlalu detail. Oleh karena, jadi kita mulai tentu terus menerus. Jadi di sini ada background studies, pengumpulan data-data, analisa data-data. Kita lihat bagaimana program-program bekerja atau tidak. Kemudian yang penting adalah bahwa sebelum kita tahu siapa pasien berikut, draftnya sudah siap, yang teknokratis. Ya, setelah itu, begitu presidennya kita tahu siapa, ini diajukan kepada presiden dan timnya. Presiden arahnya apa? Dia sudah setuju dengan draft itu atau ada prioritas khusus? Biasanya setiap presiden ada prioritasnya. Oleh karena atas dasar itu, jangan lupa ya, data alone is important, but is not useful. Karena di dalam menyusun policy ada pertimbangan politik, ekonomi, sosial, dan sebagainya, dan sebagainya. Oke? Jadi jangan sangka data itu is all in all. Pertimbangan politik kadang-kadang jauh lebih penting daripada teknokratis. Oke? Nah, setelah kita tahu siapa presidennya, dapat arahan, kita ini ini draftnya, kemudian ini musrenbang nasional ya. Jadi dari seluruh provinsi, dari seluruh daerah, setelah itu baru final draft, dan nanti pada bulan Januari Presiden akan mengumumkan ini dia RPJMN, kemudian dengan anggaran tahunan tiap tahun. Jadi kita sudah ada sekarang matriks tiap tahun apa untuk berapa untuk apa. Oke, ini terlalu sibuk, tetapi hanya untuk menunjukkan bahwa kita punya kerangka acuan untuk pembangunan di dalam RPJM 2020. Ya, jadi saya bilang sama Pak Gani kemarin, jangan kira kesehatan tuh ibor alas ya, enggak. Kesehatan aja rebutan antara bagian-bagian kesehatan. Ya, orang AIDS mau ini tidak bisa. Tapi kalau kita bekerja pada data, dengan data yang konkret gitu, tetapi juga ada pertimbangan politik, ekonomi, sosial, insya Allah ini. Nah, kita memang punya vision 2045. Kenapa 2045? Kita umur 100 tahun. Ya, 100 tahun setelah independence. Nah, kemudian setiap 5 tahun ada perumusan apa untuk 5 tahun itu. Temanya apa? Ini. Fokusnya apa? Sesuai arahan Presiden, ada 5 fokus ini, yaitu pembangunan manusia, itu nomor 1, ekonomi, kemudian regional development, pembangunan wilayah, pembangunan infrastruktur, kemudian politik, hukum, security, dan sebagainya. Ya, jadi fokusnya demikian. Juga tentu sudah dikatakan apa kendalanya, yaitu financing tentu, ya, kemudian natural resources, sering ada bencana dan sebagainya. Jadi ini sudah dalam satu kerangka. Saya langsung loncat di dalam fokus untuk human development, untuk manusia. Kenapa? Karena kita ada di sini, health ada di sini. Jadi health termasuk dalam pembangunan manusia, basic services, jadi pelayanan dasar, dan social protection. Ya. Nah, tentu ini ada kerjasama dari health dengan pendidikan tinggi dan sebagainya ya. Tetapi asal tahu tempatnya kita di sini. Oke? Nah, kemudian ada arahan. Strateginya gimana? Pada dasarnya, health policy direction-nya ini bahwa satu untuk pelayanan kesehatan, apa yang harus dipentingkan di sana, yaitu tetap meningkatkan kesehatan ibu, bayi, kesehatan keluarga, family planning, keluarga berencana, dan reproduksi. Saya senang sekali karena PP Kesehatan Reproduksi kami buat waktu saya menteri, dan itu semua orang nggak setuju. Hanya karena ada dua artikel yang dia tidak setuju semuanya. Tapi syukurlah sekarang sudah oleh Presiden ini juga dipercepat perbaikan gizi masyarakat. Dan ketiga adalah penyakit. Jadi di mana tentu penyakit menular dan tidak menular harus seimbang, tetapi itu berarti harus betul-betul diperhatikan pada pelayanan kesehatan dengan terutama pada primary care. Ya, jadi dari data tadi ya, udah lihat. Kemudian ini gerakan masyarakat hidup sehat, germas, itu juga akan ditingkatkan untuk peningkatan preventif promotif. Ya, karena kita lihat tadi, kita kalau baru mau kuratif, pengobatan, muah setengah mati, bangkrut BPJS. Tapi kalau kita pada pencegahan, kita harapkan semua itu tidak terjadi, maka preventif promotif, maka biaya pengobatan juga akan lebih rendah. Dan tentu 30% adalah biaya pharmaceuticals. Nah, ini juga suatu masalah besar. Ya, obat-obatan mahal sekali dan makin mahal. Apalagi kalau sudah pengobatan kanker dan sebagainya, itu cuma mahal setengah mati. Belum lagi alat kesehatannya untuk bikin diagnosa dan sebagainya. Jadi itu semua kalau kamu jadi Menteri Kesehatan, harus kerjasama dengan Menteri Keuangan, Menteri Perdagangan, dan berjuang betul supaya itu bisa ditekan. Nah, terakhir tentu adalah health system strengthening. Tanpa health system strengthening, tidak mungkin kita dapat, kita capai tujuan RPJMN. Nah, terakhir saudara-saudara adalah data tidak boleh hanya untuk policy. Policy yang bagus tidak digunakan. Nah, kalau tidak memperbaiki nasib manusia, ya enggak? Karena itu, yang saudara perhatikan juga bahwa data dan informasi ini juga dipakai pada seluruh proses dari policy ke action, baik tingkat nasional oleh kementerian-kementerian maupun lokal sampai ke tingkat community. Ya. Kemudian action ini kita selalu ada monitoringnya. Monitoring, kemudian evaluasi dan research di sini. Bagi saya, research itu penting sekali. Ya. Research, dan untuk kali ini ada 19 health indicators, saudara tahu ya, ada Sustainable Development Goals, ada segala macam. Nah, tetapi disinilah bahwa data dan informasi ini selalu harus ini pada policy yang baru, tetapi juga pada action. Jadi ini suatu lingkaran yang terus. Kesimpulan, keberadaan dan pemanfaatan data memampukan kita untuk pengambilan keputusan yang lebih smart, yang lebih cerdik, baik tingkat nasional maupun tingkat daerah, sehingga seluruh pelayanan kesehatan dan health outcomes lebih baik dengan biaya yang lebih rendah atau efisiensi. Terima kasih.
Terima kasih, Bu Nafsiah. Mungkin saya simpulkan sedikit ya, jadi memang dalam pembuatan health policy kita lihat bahwa effortnya yang dibutuhkan sangat luar biasa. Jadi luar biasa sulit ya Bu Nafsiah dalam membuat health policy, bukan hanya data yang valid dan konkret, tapi juga harus mempertimbangkan pertimbangan finansial, sosial, dan kemudian politik yang paling penting. Terus yang kedua mungkin tadi saya juga mendengar mungkin menyimpulkan sedikit bahwa data juga perlu dekomposisi atau di breakdown. Mungkin kalau Indonesia kita lihat geografikalnya adalah provinces, banyak provinces.
Sangat benar.
Jadi harus di breakdown dan dikomposisi untuk menyesuaikan policy di tingkat lokal.
Betul.
Itu mungkin ya, Bu Nafsiah. Kita akan buka sesi diskusi dan tanya jawab. Mungkin saya batasi 3 pertanyaan dulu. Silakan. Ada yang mau bertanya? Ya, Dr. Ediana mungkin. Ibu dan satu lagi mungkin. Ya. Silakan, mungkin dari Ibu dulu yang di pojok.
Sondang Pina, saya mau menanyakan, saya dari JID Konsultan, mau menanyakan apabila kita konsultasi melalui APPS Halodoc dan Ayodok tersebut, apakah data kita kerahasiaannya sama dijaga seperti kalau kita ke rumah sakit? Itu yang pertanyaan pertama. Untuk yang kedua, apabila diberikan ke pihak ketiga, adakah regulasi tersebut diatur di undang-undang kah? Terima kasih.
Regulasi yang mana, Bu?
Kalau data tersebut kita berikan ke pihak yang ketiga.
Data yang mana?
Data kita di rumah sakit gitu. Kalau kita bertanya di APP Halodoc gitu
ya.
Seperti
itu. Apakah terjamin kerahasiaannya
ya,
gitu
betul.
Maksudnya? Apakah
Ya.
diatur oleh
seperti
undang-undang?
Kayak di rumah sakit, kayak kita kalau di rumah sakit kan kita lebih private ya mungkin.
Oh, gitu.
Seperti itu.
Okay.
Terima kasih.
Baik, terima kasih Ibu Nafsiah. Perkenalkan, saya Ediana dari Fakultas Kedokteran.
Siapa?
Ediana.
Edi.
Itu mengambil nama dokter anak di Bandung zaman dahulu kala. Ya, terima kasih atas penjelasannya, sangat jelas sekali bagaimana tadi dikatakan dari data kemudian akhirnya menjadi policy dan action implementation. Nah, apakah data-data raw data tersebut boleh di-share juga kepada kami, barangkali nanti mungkin kami bisa melakukan suatu penelitian bersama dengan Kemenkes. Kemudian yang kedua, mungkin ini sedikit kegalauan saya, kebetulan saya sekarang juga aktif di Yayasan Thalassemia, gitu. Karena kita tahu di BPJS sudah naik peringkatnya dari 5 tahun lalu, beberapa tahun yang lalu sekarang naik ke nomor 4. Berarti di satu sisi secara pencegahannya ini bagaimana? Nah, untuk pemeriksaan karir thalassemia ini. Sementara kita tahu HTA itu sudah ada sejak tahun mungkin zamannya Ibu ya 2009-2010. Sekarang juga ada pergub dari Pak Anies 2017 sebelum menikah di KUA sudah harus diperiksa. Tapi gaung-gaungnya saya belum mendengar karena saya belum menikah lagi. Kemudian, nah ini yang pertanyaan saya, Proknas itu baru katanya akan di-launching tahun depan untuk pencegahan tersebut. Padahal selama ini kita menunggu-nunggu dan akhirnya kita bertanya-tanya ada yang namanya Germas, apakah dimungkinkan kita tidak ya mendahului berarti dari Proknas tersebut kita sudah melakukan screening itu secara massal dalam tanda kutip misalnya melalui fakultas kedokteran kita begitu. Jadi intinya adalah kemudian dari yang namanya policy, waktu itu sudah ada polisinya tahun 2010, sampai dengan implementasi, ini sudah 10 tahun. Nah 10 tahun itu kan sudah berapa juta anak-anak muda yang menikah di situ dan mereka tidak ada awareness-nya, mereka menikah demikian tanpa tahu mereka itu karir, karena kita tahu dari data di Yayasan Thalassemia itu careership di Indonesia adalah 10%. Jadi kalau kita di sini ada 100 orang, 10%-nya itu sudah sebetulnya karir tanpa kita tahu. Saya tahu karena saya karir, begitu. Kemudian apabila akhirnya kita melakukan pencegahan tersebut dengan adanya karir thalassemia screening, data itu apakah bisa kita share ke Kemenkes? Ide kami sih adalah tadinya itu bisa dihubungkan dengan IKTP, karena biar bagaimanapun juga ide ini adalah hadir bersama dengan penelitian kami dan juga dari Yayasan Thalassemia Internasional. Jadi yang ada di Italia, di Siprus, daerah-daerah tersebut yang 50% karir, mereka itu akhirnya menghook up dengan data kependudukan. Sehingga pada saat mereka mau menikah, karena mereka mayoritas di sana Katolik, mereka waktu ke pastor sudah ya sudah jelas gitu bahwa yes, kami adalah karir bertemu dengan karir. Nah, kalau di Indonesia kan mau ke KUA, yang saya tahu di Indonesia itu di paroki atau di keuskupan masih belum dimungkinkan, tapi kalau di KUA ya mereka sudah mau menikah dan mendapatkan semacam ijazah atau surat layak kawin katanya Pak Anies waktu itu. Ya, saya tidak tahu kenapa istilahnya layak kawin bukan layak nikah. Itu sih Pak. Terima kasih.
Oke.
Yang terakhir, mungkin silakan.
Good afternoon, Ibu Nafsiah. My name is Rafi, and I'm from the Joko Sutono Research Center, Universitas Indonesia. I have 2 questions, actually, Ibu, if you would allow me. First, if we see data as a way to detect challenges, trends, and so on, and political and financial and economic considerations as the process, do you believe, ma'am, that technology in this era of digital age, do you believe that technology can be the ultimate solution to solve our problems when it comes to access to health? And second, did you, ma'am, when you were Minister of Health, utilize data to detect not only health problems that we see yesterday and today, but the prices of medicine and the affordability that it can give towards the people around them? Is that important? Or I'd really like to see your take on this. Thank you, ma'am.
Thank you. Okay. Terima kasih. Thank you for your questions. Sondai, ya. Ibu Sondai. Saya terus terang tidak ada pengalaman tentang halodoc atau apa gitu, tetapi in principle semua yang sudah di internet sulit sekali untuk dirahasiakan ya. Jadi memang apakah sama dengan kerahasiaan di rumah sakit? Ya jelas tidak. Yang di rumah sakit yang kita rahasiakan adalah Ibu Naf sakit TBC. Di halodoc saudara tanya TBC itu apa? Obatnya apa? Ya, jadi beda kerahasiaan antara keduanya itu. Jadi menurut pendapat saya, dan jelas saya bukan expert ya, tapi di antara saudara-saudara ada yang bisa jawab bahwa apapun yang ada di internet jangan mengharapkan kerahasiaan deh. Ya, kalau memang ini ada yang perlu dijaga kerahasiaannya, pakailah cara lain. Jangan internet. Walaupun harus saya katakan bahwa di dalam RPJMN 2020-2024 salah satu yang akan dimajukan juga adalah teknologi. Akan tetapi memang perlu diketahui teknologi itu bisa dipakai kapan, di mana, untuk apa, untuk siapa. Jadi tidak semua asal namanya teknologi. So Rafi, answering your question, excuse me. No, I don't think technology is the ultimate way to solve all our problems. It can facilitate. During my time as Minister of Health, indeed, we have introduced e-procurement, e-catalog, etc., but not to solve all our problems, but to facilitate the distribution, to facilitate procurement. So much so, also, actually, at that time, we introduced the e-system to diminish the opportunity for corruption. When I became Minister of Health, one of the information that was given to me was, poor you. You are Minister of the most corrupt department in Jakarta. It was not so. But since my first day, I said, okay guys, I don't believe that we are all corrupt. Maybe in the Ministry of Health, there are 10 or 15 people who are corrupt. But all the others, we can prevent corruption. And one thing to prevent corruption, among others, was using the e-catalog e-procurement and all that. Also, we introduced e-learning because during that time, there was the regulation of the Ministry of Education that suddenly nurses have to be S1 or diploma or whatever. And of course, that means thousands of pembantu perawat, assistant nurses in the era were not able to work. And I said, I cannot accept that because I've been working in the era and they were very, very useful. Jadi asisten bidan, asisten perawat, etc. But they cannot have S1. So we then made the agreement with the Ministry of Education, because that's again another anomaly, that education of health staff is the responsibility of Ministry of Education, and now Minister of Higher Education even, and we are the users. So it's a whole mess, I can tell you. So what we did was institute the e-learning. We discussed and we agreed with the Ministry of Education the knowledge that needed to be taught to all these thousands of diploma in assistance, and did it by e-learning so that they were able to get their S1 and get to work. Okay, so I see technology to facilitate, not the ultimate solution of all our problems. Maybe not in my lifetime, maybe in your lifetime, okay? Okay, Ibu Ediana ya? Ediana, apakah raw data bisa di-share? Usually not, biasanya, dan ini bukan raw data ya. Yang saya tunjukkan adalah data yang sudah dianalisa, dan sudah dibakukan, dan sudah di-agree to. Misalnya, raw data yang ada itu dibahas bersama antara IHMI dengan apa namanya? Dengan Kementerian Kesehatan, Litbangkes, kemudian mereka bikin apa yang seperti ini, burden of disease dan sebagainya, kemudian mereka kirim kembali kepada kita untuk divalidasi. Kemudian teman-teman dari Litbangkes ke ke daerah untuk cek satu persatu per provinsi dengan kabupaten kota yang ada, ini benar nggak? Contoh, kadang-kadang lucu. Di salah satu provinsi, boleh ya? Masih ada waktu? Boleh. Di salah satu provinsi, mereka bilang TBC sudah meningkat, sudah menurun. Waktu mereka ke provinsi itu, mereka bilang, iya, kita punya program TBC sukses, TBC sudah menurun. Di rumah sakit bilang, enggak kok, di kita malah meningkat tuh. Nah, dalam hal demikian, penting sekali bahwa ada kesepakatan bersama angka yang mana yang kita pilih. Oke? Jadi, satu persatu data yang sudah diolah di IHMI, itu dibawa lagi ke daerah untuk divalidasi. Itu yang dikirim, kemudian tiap tahun, di sini namanya kolaborator. Itu kolaborator bisa mengirimkan data atau mengirimkan komen. Nah, can you have access? Apakah saudara boleh akses pada data-data ini? Yes. Silakan itu open public kok. Jadi pertama ada di healthdata.org. Itu dari IHMI. Satu kata. Healthdata.org. Siapa yang pegang ini bisa di itu. Bisa di itu. Kemudian saudara bisa mendaftarkan diri menjadi kolaborator. Namanya kolaborator. As collaborator, you bisa akses, you bisa akses semua data. Ini semua open data. Begitu sudah menjadi bagian dari Global Burden of Disease dari IICB, itu semua sudah saudara boleh pakai untuk penelitian atau untuk presentasi, untuk apa, boleh. Ya, asal sumbernya taruh di situ, healthdata.org, organisasinya atau institut adalah Institute of Health Metrics and Evaluation, IHME. IHME. Itu, saya itu. Oke? Jadi itu bukan raw data ya. Raw data biasanya kita tidak share. Tidak pernah di-share. Kalian juga kan kalau peneliti mesti sesudahnya. Nah, thalassemia, I'm very happy to hear that. Meskipun saya bukan lagi dokter anak, ya, saya sudah tidak berhak. Oleh karena saya sudah tidak praktek sebagai dokter anak sejak tahun 80 berapa gitu loh. Ya, begitu jadi istri gubernur saya sudah nggak bisa praktek. Jadi saya hanya praktek kira-kira 14 tahun. Nah, tetapi apa yang yayasan bisa lakukan? Karena what you were saying was right. Pertama, kalau bisa yayasan melakukan pendidikan kepada masyarakat. Dan tidak usah pakai pakai ceramah dan sebagainya. Sekarang dengan cara digital. Nah, di sini saya rasa digital facilitating. Pakai media sosial. Jadi itu cepat sekali kemana-mana. Pakai e-education dari masyarakat. You juga bisa kerjasama dengan yayasan-yayasan lain yang kira-kira dalam bidang yang sama untuk bisa mengeluarkan informasi yang benar, satu. Kedua, mendorong supaya setiap setiap orang, laki-laki maupun perempuan yang sudah didiagnosa itu bersedia untuk ke kalian, kemudian bersedia diberikan pendidikan supaya anaknya atau saudaranya atau keluarganya dites sebelum menikah. Karena tentu dites sebelum menikah lebih baik daripada kalau sudah menikah, ya udah. Ya. Jadi kalau saya itu, kemudian saya setuju sekali kalau yayasan melakukan advokasi untuk menginikan program nasional tersebut. Oleh karena memang terus terang, ini pengalaman juga sih, kalau dari undang-undang, terus peraturan pelaksananya, ada peraturan pemerintah, ada peraturan Menteri Kesehatan, ada peraturan ini, tapi biasanya itu semua nggak keluar. Lalu kalau nggak ada peraturan itu nggak ada terjadi, nggak ada implementasi. Jadi memang menurut saya civil society dalam hal ini yayasan thalassemia bisa mempunyai peranan yang jauh lebih besar. Tetapi juga universitas misalnya. Kalau seperti tadi kalian katakan, Ediana bilang, bisa nggak kita di universitas ambil program seperti itu? Sure, bikinlah education, program pendidikan kepada masyarakat, jadi join Germas, betul, bikin program pendidikan kepada masyarakat, bahwa ini hal yang bisa dicegah. Ya, sebab begitu anaknya lahir dengan thalassemia, pengobatannya memang mahal, tetapi juga sengsara untuk anak dan keluarga. Jadi pendidikan untuk pencegahan, dan memang itu menjadi salah satu tolok ukur prevention di RPJMN 2000.
Oke, baik, masih ada waktu, mungkin kalau ada waktu nggak panitia? Maaf, sudah. Berikutnya. Okay.
Excuse me, Ravi, what was your second question?
Actually, my second question was, when you were Minister of Health,
yes,
did you utilize data to find out whether people around Indonesia was able to afford the medicine that you were distributing?
Oh yeah, not only the Ministry of Health.
Oh, everyone.
The affordability and accessibility. Actually, it's not only affordability; it's also accessibility of medicines. Well, especially those that are being served by BPJS, okay, who have enrolled in the social insurance scheme. Of course, from the Ministry of Health, the first one is all medicines have to be generic. Okay? So, indeed, if it is branded, which is very, very expensive, cannot. It has to be generic. So the first task of the whole system is to ensure that all generic drugs are affordable, and certainly that is so, but also that they are accessible to all who need it, wherever they are. That is why it's so important to know which diseases or which risk factors are in which province at kabupaten kota, so that up to the primary health care, they will be able to order the medicines that they need. Okay? So generic drugs certainly are affordable because they can all be claimed to the BPJS. But if they're not, that is another issue. At the moment, indeed, especially if you go to private hospitals, etc., and private doctors, they really like to give you branded medicine. Indeed, a lot of them is not affordable and also not accessible. Because they are not affordable, we don't put them in the program to be purchased through the e-procurement. That's clear? Thank you.
Oke, mungkin karena keterbatasan waktu, we will move to the second session. Sorry,
Sure.
terima kasih. Tepuk tangan sekali lagi pada Ibu Nafsiah. Okay, so we'll move to the second session. It's a Professor Raj. Professor Raj he's a visiting professor from University of Houston College of Pharmacy, and he's a professor of pharmaceutical health outcomes and policy. And today he will present about the data for evidence-based health policy.
Good afternoon, everyone. Thank you all for being here, and I really appreciate the talk by Ibu Naf. And I'm still trying to get just to Indonesia. I've been here for a month, and I'm really enjoying my visit. I really enjoy the people, enjoy the discussion with the faculty and students. I'm here for Atma Jaya as part of the Fulbright and MNF, and I'm really excited to be part of this panel to talk about health policy. Most of the work I do is in the area of pharmaceuticals and other kind of health policy issues. And I'm going to give you a different kind of perspective because Ibu Naf talked about some of the aspects related to policy and politics. So I'm not going to touch politics at all. So there is no way that I can touch politics because each country's politics are very different. I'm going to come up with a different kind of perspective, especially being in academia and in terms of what I can contribute in terms of both evidence as well as policy making, which is much more rational and which we're more focused on improving patients' health or population health. So as you can see, this is my kind of overview. I'm going to talk about a little bit of evidence-based medicine. Then I will get into evidence-based health policy, which has been very important in most of the developed countries, and it is increasingly being used in developing countries. I'm going to talk about the evidence-based health policy process, and I'm going to talk about the importance of data for evidence-based health policy and some of the examples of data as well as the policy making which is involved. I'm going to focus mainly from the developed countries because the most of the data which I work are coming from the developed countries, and I understand the ramification issues related to data coming from developing countries, and probably you are more aware of those issues than I am, so I cannot really comment about that. And I'm going to talk about some of the emerging issues related to the data, and finally I'm going to do some conclusions. So as you know that right now there is increasing use of evidence-based medicine. And the reason we are using more evidence-based medicine is because medication use has become really, really complex. And the other reason is that there is a growing evidence. Some of the evidence is coming from randomized clinical trials. Some of the evidence is coming from observation studies. And the word evidence-based medicine was first coined in 1991 at McMaster University. And it is basically changed the way we do clinical practice and the way we teach students in terms of clinical care. And I want you to think about this very carefully, because evidence-based medicine is not new. It has been used in each and everything we do. For example, if you're talking about teaching, we want to use evidence-based approaches. We want to see how the students are learning, and then only we can teach the best way. So I want you to think about evidence-based medicine not on its solo, but it has been used across the spectrum in terms of the various profession and organizations. So evidence-based medicine is nothing but systematic framework in answering a question in clinical care. And I want you to think about this one. I think we need to have this process in terms of the way we answer a question in a systematic approach. Okay? So first time when they started to use the word evidence-based medicine, the focus was mainly on evidence. And I'm going to talk about that one. Because at the time when we talk about how we're going to do patient care, I have to listen to my professor, I have to see what is happening in the clinical practice and say that's what I'm going to do. Yes, that is important. But now there is a growing evidence. What I'm learning from practice is much more which is happening in research and other kind of setting. So if you look at the evolution of evidence-based medicine, it has three components. Research evidence is important, clinical expertise is important, and then patient values. These are the three. If I cannot factor in all those things, I cannot provide the best care. And I want to think about that when we get into evidence-based health policy, because this is really vital. We need to have the evidence. We need to have the expertise. And I think Ibu have also talked about that one. Just data alone is not going to do the job. We need to think about something else. With respect to medicine, we need to talk about the expertise we have, and also with respect to patient values. And the reason I want to kind of emphasize the expertise, especially in clinical expertise, is sometimes we do not have the information to make the decision. And that is true with respect to policies and procedures also, right? If you don't have evidence, we go with the expertise we have, the knowledge we have gained over the years. So it's really important. So I want you to understand this new paradigm with respect to the three things we are talking about. As I said, the reason we are focusing on EBM is because there is too much of information, too much of evidence which is coming from randomized clinical trials and observation studies. And there is more and more data and evidence available, especially with respect to clinical care coming from the developed countries. And these days, everything is computerized. If you look at the US and UK and Australia, and right now it is happening in each of those things. And I think I was looking at the examples, and I think for me it was important to understand there is more data being collected in the applications which is being used. And so we'll talk about that hopefully. And the other thing which I want you to understand is that if there is a greater generation of evidence, it is very critical that we translate that evidence into practice. Otherwise, we are not doing the job. I'm talking about clinical care, and I will get into health policy shortly. And the most important thing is the reason we want to use the best evidence and the newest evidence in terms of patient care is because we want to provide the best outcomes to the patient. We don't have a choice. We have to do that given the resources, infrastructure we have. So as you can see, in order to provide evidence-based medicine, we need evidence, which is high quality evidence, and we'll talk about that once we get into policy. We need clinical expertise because evidence alone will not do justice. Some of the new diseases which are coming up, there is no evidence. What do we need to do? We cannot provide care. We still need to provide care, but we need to do the best we can in terms of the information we have or the resources we have. And the other thing which I want to be focusing on this one, this is very, very important. It has come up in the last 10 years. We need to value patient beliefs and attitudes. Even if you're trying to do the best to the patient, if the patient doesn't believe in it, they are not going to do that. And this is equally important in policy. Just because evidence is saying, but if the values of the country do not believe in, it is not going to happen with respect to the policies. So I want you to think about that, what as a country we value in order to make a difference in terms of improving patient outcomes. So these are the three things, and I think right now there is going to be evolution with respect to what we do in terms of EBM. And again, I'm not going to go dwell on the EBM, but this is basically a 4-step process in terms of we want to ask an answerable question, We need to find evidence, we need to appraise evidence, and we use that information in patient care. Right now, we are teaching this across the healthcare profession. It doesn't matter whether it is medicine, pharmacy, nursing, social work, because we need our students to be lifelong learners. Just because they have graduated from our college or school doesn't mean their learning is going to stop. They need to appraise what's going on currently right now in order to make a difference. And that is true as a teacher too, right? What I have learned to be the best teacher is not the same. The way the students are learning is changing. So I need to evolve in order to provide the best care or best teaching I can for the students, and the same thing too for the patient care. And I want you to understand the way we evaluate evidence. Right now, for the clinical care, the best evidence is coming from systematic review and meta-analysis, then followed by randomized clinical trial. And then we have observation studies. With respect to policy, right now, you are not going to find systematic reviews and meta-analysis that much. You are not going to find randomized clinical trial. Policy making is not randomization. Policy making is not randomization. Policy making is purely observation. If politicians decide, if the country decide that I'm going to implement nationalized healthcare policy, that's what they're going to do. And we as a researcher, we in terms of evidence creation, we're going to look at that. So if you look at the policy making aspect of it, most of the information is coming from the lower area. Observation studies, cross-section studies. All the epidemiological studies which we have talked about in IPP discussion are basically cross-section studies. And we'll talk about why it is so important to look that kind of information for health policy making. Epidemiology played a very important role in terms of EBM. Now it is playing a very important role with respect to health policy. If you looked at the previous presentation, most of the information with respect to morbidity and mortality are based on prevalence, incidence, morbidity, mortality. All of that is epidemiology in order to make a difference in terms of country's outcome or patient outcomes. Now this is what it is. How do we define evidence-based health policy? Evidence-based health policy integrates scientific evidence with community preference and values. This is very important. The thing is, evidence has to be there. I know probably we need to put the other aspects which are going to come up, especially in developing countries with respect to infrastructure, feasibility and all those kind of a thing. But these are the critical things. Right now, as a country, the Indonesia decided that we need to have the nationalized healthcare system is because they value access in terms of healthcare. And we'll talk about some of the political issues as well as policy issues related to those access. But it is very important to combine those two, evidence and societal values, in order to improve patient outcomes. Okay? So I'm not going to go with respect to each one of those steps, but what I wanted to emphasize is that whatever the issue come up, we need to quantify it. For that, we need data. Whatever policy we want to make, we want to look at what is the best policy we can make. That is going to come from previous work. Then, once the policy is implemented, we wanted to see whether we are making a difference in terms of population health. Then we need more data and more research. So if you look at evidence-based health policy making, you need data for each one of those steps in order to improve population health. And it is really important for every country, doesn't matter if it's a developed country or developing countries, because we want to use our resources efficiently. Without evidence and without data, it is tough to do that. Have some water, please. As you can see, I get very passionate about some of those things. I'm getting some of that energy from you too. So this is the challenges we have with respect to health care. We want to improve health based on addressing access, cost, and quality. An ideal system is going to provide access to quality health care at reasonable cost. It is easily said than done. It doesn't matter whether it's a developed country or developing country. And the biggest challenge is that it is interactive relationship between those three. Cost, access, quality. If I provide access to everyone, the costs are going to go up. It doesn't make a difference. if I want to improve the quality of healthcare, the costs are going to go up. See, there is no magic formula. You need to address those things. In order to address those things, you need to work with the system. You need to work with data. You need to work with evidence. So I want you to think about those things. It is very, very, very challenging. For any kind of healthcare system, doesn't matter whether it's UK, Australia, US, there is an evolution in terms of healthcare. We slowly evolve in terms of how to manage those tricky situations. Everybody talks about that, in terms of developed countries. This is good, this is not good. But there is no perfect mechanism. Indonesia, I think you have started with a nationalized healthcare system. Now it has addressed the access. You need to start focusing on cost and quality. Those are going to come up. And I think I want you to think about that and how data and research will play such an important role. And I'll talk about that. I think there was one of the questions raised with respect to access to data. For I really strongly believe in that, coming from academia, doing research with respect to healthcare policy. With respect to data, you already know that we can collect primary data, and there are a lot of institutions, I think World Health Organization, other kind of organization fund that kind of work, but it is very, very expensive. In addition to that, there is a secondary population data collection. People collect data for various reasons. In this country right now, because of the nationalized healthcare, data is going to be collected. It depends on how you use the data for making the best evidence and best analysis. You have to think about that one. And those kind of solutions are not going to come from only one group. I'm not just talking about government. It has to come from several. And I want to talk about some of the other extreme examples in terms of how the marketplace is changing. Google has collected so much of data not because they've collected the data. People are contributing the data. And they are using the data to make the best products. And some of the solutions with respect to applications are not just coming from Google. They are coming from each and every company, each and every organization, each and every entrepreneur. So I want you to think about the solutions for health policy are not going to come from just government. I understand government is the one who's going to make policies and procedure. But I want you to think about the solutions based on data and research are going to come from various sources. So why it is so important to have that data so that we can come up with those things. Of course, we also have qualitative data. These days, like policies and procedures are sometimes driven by qualitative data. If some constituent comes to the politician and says this is not working, they are going to act upon it. It doesn't matter how effective or how big the problem is. And I'm not saying that is not right or wrong, but I wanted to say both quantitative and qualitative data are important to understand the issue. Okay, so how do we use evidence in terms of health policy? We have already seen those many examples. I don't have to go in that. Each and every study we do with respect to disease burden will help you to understand where I need to spend my healthcare dollars. If stroke is the #1 disease, we need to spend resources and infrastructure so that we can reduce the morbidity and mortality associated with stroke. That is very important for a country, region, community. The other thing which has to happen is that we need to look at what are the effective intervention and effective policies. That is going to come from the research previously done. It is also going to come from the policies we are initiating each and every time. Every time we are making a policy decision, it has consequences. So I'm talking about we as a society, should be looking at the cost and effectiveness of each and every policy decision, because this is our government, right? So I think I'm mainly talking about academician. As a researcher, we need to come up with those kind of solutions to see if some things are working and some things are not working. And it is really vital to understand. And the most important thing why it is so important for me to do research with respect to the data which is collected from different sources is that I want to make sure that I contribute to the improvement by the government for the policy making. It's very important because healthcare policy is incremental improvement. I can give you a lot more examples with respect to US and when we have time. But I want you to understand whatever system, whether UK has, US has, Australia has, it has not come up with just like that, with a stroke of a pen, making a policy. They made incremental improvement in terms of what has to be done in order to improve population health. So I'm going to give you 3 examples from all developed countries because we already have example from Indonesia. This is one example where they've used data in order to improve patient waiting time in United Kingdom. And they made what you call decisions or policies related to patient's choice, management, and hospital rating. They had a hospital star rating so that people can pick where they want to go. And they use the national health data, trust data, because it's a nationalized health system, it's much more easier to do research based on that data. And it is very important that we use the data so that we can come up with those solutions. And if you look at how the information has been used, size of the problem, prevalence and incidence, equitability. Equitability is one of the goals of this country also, because each and every person, doesn't matter if it's urban, rural, island, other kind of a thing, should have equal access to healthcare, equal access to quality healthcare. Equitability plays a very important role. And we also want to look at equitable gain and intervention effectiveness. The reason I want to say that national data has so much of value when you want to look at the policies made at the national level, which can be easily addressed when we do use the data to make decisions. I know that some of those decisions can be done by the government, but there are a lot of other answers can come from other researchers, other partners who are involved in using the data. This is an Australian example where they wanted to improve immunization rate by requiring immunization for family benefits and schools. And they used multiple data sources to look at that. The policy was that everybody who's getting family and school benefit need to be immunized. So they wanted to look at, by requiring that immunization, what is the effect of immunization. That is what we call as a process measure. Again, they use national data sets to look at the size of the problem. They looked at equitability, policy effectiveness, incremental gain. So population-based analysis has become really, really important tool to understand where we are, what we need to do, and how we need to improve. This is United States example. United States, there is no centralized healthcare system. But there are 2 systems which are there. That is insurance which is covered for poor, which is called Medicaid. Insurance which is covered for elderly, which is called Medicare. So Medicaid and Medicare, those are national systems, are funded by national and the state for the Medicaid. And we are using those national systems to improve the quality of the medications which are marketed. I do extensive research based on these national data sets. As a researcher, I have access to Medicare. I have a researcher, I have access to Medicaid. This is the national data, and this is electronic health records data, and all the information which is here can be effectively used. And because of that, I can find out how many patients are getting inappropriate medication. What is the effect of medications on patient outcome? They are classical examples. Because of the researchers' work, products have been withdrawn from the market. A classic example is a COX-2 inhibitor, the Vioxx, which has withdrawn from the market because the research was done on those data sets which are provided based on the national healthcare system for Medicare and Medicaid. Right now, FDA is relying on what we call is evidence coming from those national data sets to make incremental improvement with respect to approval process. Right now, most of the safety research is driven based on these population-based data sets. And this is not done by the government. This is done by individual researchers who are working in institutions. Of course, they are funded by various organizations and national agencies. And if you look at these data sets, they have a value to provide. I understand, once you are local, you understand the richness of the data as well as issues with respect to reliability and validity. But with respect to this data, I can look at the rare effects. I can look at the long-term effects. I'm working on antipsychotics over the years. Now, because of the work we have done, not only me and other researchers, there is a black box warning for antipsychotics because they should not be prescribed for the elderly. And as you can look at the domains of evidence, it needs to have a structure, it has to have a process, it has to have outcome. For all the things which I want to do, I need evidence for policy making. So, as I strongly believe, developing countries should build the infrastructure and national capacities for data collection, management, and analysis. It is very, very important now that Indonesia has a national healthcare system. There has to be a way we can enrich the data through standardization, quality improvement, both reliability and validity has to be addressed. That data needs to be shared for the national interest. And I'm not talking about just because one country is doing it. It is the marketplace which is going to do that. I know some of you have talked about the applications which are capturing the healthcare data. It is going to be monetized. I'm 100% sure all the agencies which are collecting the healthcare data, it is going to be monetized. Now, I'm not talking about monetization of health data. I'm talking about using the data to make a difference in people's life, to improve patient outcomes of the nation. We need to protect and respect the integrity of data collection agency. This is very, very important. All the data has to have some kind of a rule in terms of what can be shared, what cannot be shared. This is the patient data. Who owns the data? No, the patient should own the data, not insurance company. This is very important. I want you to understand this. As a patient, if I'm visiting a physician, I'm responsible. I have to give permission. And I want you to think about that. I'm not saying there has to be evolution in terms of what we do, but I want you to think about those things which are slowly going to come to make a difference. And I strongly believe there has to be greater collaboration with respect to data between the government, academic institutions, and researchers, because the solutions are going to come from across the agencies, not one agency. We as the people have to make a difference. It can happen in academic setting, research setting, government setting, and community settings. And I strongly believe, and I think some of the examples which are shared also are equally important, that health policy research needs collective efforts from all the people who are involved. Data collection, data management, usage, making decisions. These are the people who have a lot more information which they can contribute.
Maybe could you be faster?
Yes, I have one more slide, I'm done.
Sorry.
No, I understand that. So as I said, these are the data tables which you have already seen, but these are the areas where we can have a good solution. I think already data has been collected with respect to that one. And the future of data, as you can see, this is what I'm talking about. Right now, there is a big focus on what we call is a big health data. Some of the solutions are going to come from this predictive modeling tool based on machine learning and deep learning. We can learn a lot in terms of what we can do in terms of population health coming from those tools. But that require a lot more effort on infrastructure, data collection, as well as analysis. And more is going to come up. And I'm 100% sure in terms of how we are evolving with respect to data infrastructure. With that, I strongly believe that evidence-based health policy is vital to achieve national goals. Data and evidence are needed for efficient in terms of what we do with respect to evidence-based health policy. As you can see, there are several examples, and I know that there were examples from developing countries also, including Tanzania and other, where they've used the data in order to make a difference in terms of population health. And I believe the national health data should be a priority for the nation, because it can be valuable resource not only internally, externally, because it's going to play an important role in terms of improving patient health. Finally, I strongly believe there has to be greater collaboration from the government, academic institutions, researchers, and even others who can contribute in terms of coming up with the solution with respect to health policy. With that, I'm going to end my presentation. Thank you very much.
Thank you very much, Professor, for your great presentation. So I find it quite similar with evidence-based medicine, with evidence-based health policy, that the data cannot stand alone, I guess. to decide anything in clinical or policy, right? We need expertise and people values. Right. Okay, because we're short of time, we're moving to beautiful Lua here. Beautiful Lua. Okay, Lua is a Ph.D. candidate from London School of Hygiene and Tropical Medicine. He's in Health Policy Department. Am I right? Okay, and okay, and she will try to explain about how to use the data from the unconventional sources for health system strengthening. Okay, so 20 minutes for you, Lua.
Thanks. This is not my thing yet, but wait, I have to do this. Thank you very much for staying awake until I came on. Appreciate it. It's really a great honor for me to be on the stage and sharing it with such illustrious colleagues, and I really have to thank my in-country supervisor, Beth, for inviting me here today. I'm going to not be so popular, I think, with my colleagues once I do my presentation, because as you'll be able to see, I'm quite not mainstream when it comes to my research. And this has been a problem pretty much throughout my career. I'm not a medical doctor, but I'm interested in health. I started off in politics, and then I shifted over to healthcare management, and now I'm more on the health policy side. I will go down, and then you can see a little bit about me. I put my 3 favorite jobs in the last 15 years up here, just so you can know a bit about me, because otherwise if you Google me, you'll get all sorts of really random stuff. Please don't do that, it's embarrassing. But as you can see, I started off as somebody who wanted to save the world, and that has kind of progressed, and I've just become a little bit more systematic about how I go about it. My background is very international, and that influences how I think and how I speak. I was born in Guatemala. My father's Guatemalan, my mother's Canadian. That's why I look confused. I didn't spend any time in Canada, although just as kind of an ironic twist to fate, Raj mentioned McMaster University. That's in the hometown where my mother comes from. So clearly I have public health vibes. I then moved to Ukraine because of my husband, who's sitting in the back with the cute glasses on. That's him, he's here supporting me. And I started working with an international organization, again, more on the social determinants of health, I would have to say. The organization I was working for was concerned with migrants and migrants' health. And at that point in time, anybody who didn't look very white was the target of hate crimes. And so we were working with the government to fix the laws. We were working with students to try to create friendships between people and create those bridges. And that kind of set me on this path towards looking a little bit beyond the mainstream, because a lot of the problems that we are dealing with today in the world cannot be boxed carefully. They're very complex, they adapt. The more you try to solve them, the more they kind of evolve and change. And I became very interested in systems and how systems can influence people and how people influence the system's return. And I somehow ended up in the Philippines as an academic. And I was teaching health sciences program students and development studies students, and we were going out into the community and trying to save the world on a grassroots level, and failing, because that's what we do. And that kind of made me think that maybe there was a way to look at it a little bit more systematically, or approach things from, again, this more systematic point of view. And I started getting interested in unconventional data sources, and in particular those that can influence policy making. And because my heart will always be health, even though the rest of me looks very social sector, I've included people and started to focus my research on something that I could contribute to Indonesia, because I've been here for a few years and I'll be here for some time longer. So the context that I was attracted to is one that you're very familiar with and that you've already been asking questions about. So if you notice, the context that I was most attracted to is also the one, coincidentally or not, that the government is pushing in the midterm development plan. Everywhere we go, we're hearing about the Industrial Revolution 4.0 and this digital transition, and how the government is going to go E and public services are going to improve magically. And women will be empowered because digital. Which is cool, but you know, it's fine. But it really kind of brought to the forefront that Indonesia in particular is dealing with, I would like to call it, because we're health people, a double burden of issues. Not diseases in this case, but issues. Because on one hand, we're still fighting against the basics like typhoid, clean water, maternal mortality. And on the other hand, oh, sorry, you guys can't hear me, yeah? Ha! And on the other hand, we're also here in Indonesia dealing with the problems that developed countries are dealing with. We're suddenly having all these technological, ethical questions, like how much and to what extent can technology influence health? Can we put our health information into an app and believe and trust the information that comes out of that? Can we use the HaloDoc app, for example? Personally, I love Gojek. It's great. And I really enjoyed having the ability to buy medicine using Gojek. In other countries, when you get sick, you basically just wait for somebody to take pity on you and bring the medicine to you. Here, you don't have to like hire somebody to go and get your medicine and bribe them with cakes. You just go on Gojek and you're like, I'd like this, and it comes. This is amazing, but it also puts it into a very different problem category than the usual when it comes to developing countries. Now, one of the things that I often hear, especially when I travel so much, is you don't understand, you're not from around here, it's different for us, we're developing, we're developed, we're this, we're that. I'm sorry. We're all people. We all seem to be having the same problems regardless of where we're living. We got to find solutions. Now, one reason that I chose Indonesia as the place to explore this is because if you look at the stretch of Indonesia, it's about as long as Europe is. If you look at the diversity of Indonesia, it's about as diverse as Europe is. Where does everyone always want to go? Europe. But this also gives us kind of an opportunity to try things out, fail, try some more things, fail again, and by the time that we've found a solution that actually works, they won't have figured it out yet either. But because you've got only one country to play with, you've got a lot to play with. All right, so that brings me to this idea of direct citizen contact with the government. And there's actually a strong history of that here. You guys probably are aware that SBY was the first one. I think he used Twitter or Facebook or something. He was talking directly to people. Anyway, so starting from that time, there's been more of a push towards this. In 2011 or 8, Indonesia joined the Open Governance Partnership and agreed to open the data and work together and collaborate. One of the things that came out of that was complaint system on a national level. What wasn't so clear when I first started was complaint systems eco-landscape, I guess you would call it, was already very well developed, and there's already a lot of complaint systems here. So it becomes kind of a big mess. And when I then started looking more, because again, health, and I came across the universal health care and how it was just kind of, one day there was not universal health coverage, the next day, here we go, we're gonna get it done. This is a level of ambition which is really amazing, and you can see my first thought. It's still my first thought, even to this day. But I started trying to figure out, because remember systems, how do I do this, how do I bring it back down? And I noticed that the literature, as always, is very much focused on the technology and it's focused on the process. And this is very quantitative. There's always this like focus on the quantitative side of things. And so then I just started wondering, I'm like, data is fine. I mean, technology is fine, process is fine, but you're generating a bunch of data, and what's the data for? Are you generating the data for data's sake, or are you generating it for people to use it? And if you're not generating for people to use it, why not? Where's the people in all of this kind of mix of things? We didn't kind of, I'll use a quote that I heard from a very smart Korean person who was talking about smart cities. He said, we didn't end the Stone Age because we ran out of stones. And I always think of that when I think about this, because right now we have a lot more technologies and we have a lot more options, and we have a lot of things that could be much more efficient than the old ways. It's just up to us to be a little bit creative on how we use it or how we go about it. So coming back to this, I started looking into how to use complaints data, specifically health complaints data, to influence or contribute to health system strengthening, in the sense that it is a way of getting a timely and kind of direct snapshot of on-the-ground realities. People are feeling or experiencing something. Generally, they'd have to experience it quite strongly before they would complain. So if they have made the effort to complain, it's something that's big and it's probably underreported. So if you can look at a whole bunch of those types of reports, you'll get a picture that may be surprising. You might be able to see things that are unexpected. So I started then looking to see how that would relate to other health data that's already collected. So if you look at the provincial level burden of disease, for example, and you see one area has very high rates of, let's say, stroke, you could then look at the complaints data and then see what are the people saying in terms of health in that specific area. And then you might be able to already have an idea going in if it was a question of access, or if it was a question of infrastructure, or perhaps they just ran out of drugs and they were complaining that the generic drugs weren't available. And then you'd be able to be more efficient in allocating the resources. Sorry, you're right, this is really dying up here. Air conditioning, love it. So then you could use that to kind of not draw correlations, because it's not strong evidence, but it's definitely not anecdotal either. You'd be able to use that to focus your limited resources and time and funding to investigate further what exactly it is. This is kind of an important aspect for me, because let's go back to smoking. It's a popular topic here. Does anybody in the room think that smoking is not good for you? Or is good for you, or it has no impact? No. Everybody knows smoking is not good, it kills. And if you ask, so why do you still smoke, or did you know that it's unhealthy? Everyone's like, yeah, I know, but. And that I know, but is where I want to explore with my research. I want to understand the motivations or the reasons for why data is being used or isn't being used. What are people complaining about? How can it be more systematic? Those types of things. This is what I'm focusing on. I could have picked probably an easier target audience, but never one to go for the easy route. I decided to talk to at least 3 groups of people. So I'm talking to government officials, and I'm asking them what's their strategic vision, what's their guiding principles for complaint systems, is there any use for data that they currently are using, is it a tool that they're using for making decisions, or is it just a tool for them to feel like they're responding to the people and looking good? Then I'm talking to the health service providers, because often these guys are the ones that are neglected, I would have to say, and also the ones who bear the brunt of the complaints. And I'm asking them, how reliable do you think this data is? Do you think that people are complaining and then like they shouldn't be complaining about these things? Do you think that these are actually grounded in some sort of reality? How do you respond to these? How does it influence your planning for the next year? And then I'm talking to, as you can see, interesting individuals and academics and civil society, because I think that a lot of times this communication has to actually have a full circle. And if people on your level have access to this data, which by the way is open source, you would actually be able to come up with these pictures and then ask those questions to people when you get access to them. And then I'm also looking at the actual health complaints data. And I've requested the data sets, they haven't come yet, but they're coming, to see what I can show on both the data visualization side, but also how to use an unconventional data source for something that is more mainstream in its policy making. So if I can somehow get a data set and then demonstrate that by looking at these trends and then comparing it to something else, you can get some insights about regional disparity or how the distribution is, then it might encourage the focus of the overall system on the data analysis section. Because I think there's so many rules and regulations, it's very easy to just do the front half and neglect the last half. And so unless you can know or have some sense that it's valuable, people aren't going to invest the time and energy in forcing somebody to do it. And as you can see, my overall aims are below, they're very beautiful. I am having some trouble getting people to talk to me, so if you are one of those 3 categories and you would like to talk to me about these things, you are welcome. It would be better if you had, some complaints data experience, but if you don't, I can work with that too. Yeah, almost 15, and I think the next one is just kind of a thank you slide. Oh, I have a thing. I'm so used to having people doing stuff for me. All right, so that's, I'm slightly more nervous talking about this. Usually I'm very confident and all these things, but it's a really new topic area also for me, and it's also kind of a new topic area bringing together different strands in different sectors. And it doesn't hold up to a whole lot of scrutiny, but I am ready for it. So if you guys can pick some holes in my research before I have to go in front of the assessors, that would be really great. If you can think like something that I haven't thought of or some ideas, also really helpful. But otherwise, I guess my challenge or my leaving thought for you guys is, don't let the outside world dictate what you do with your country and your data. You are already miles ahead in some ways, and there's no reason not to use that momentum and just kind of coast on through to some really remarkable, stun the world, go for it. And if I can help you do that, great, but otherwise, there's so many smart people here, and they're coming back and they're doing things. It's within your grasp to do what Gojek did for Indonesia and the rest of the world with the health system and with the unconventional data sources. Just have to be a little creative.
Okay, thank you, Lua. Thank you for the great opportunity to at least see what are you doing in the research. It's really information, full of information and helpful. And maybe I will try to summarize the importance of the three incredible presenters today, where we found it similar that the approaches of quantitative and qualitative both are really important. And as we see, there are similar, actually, conclusion within the three incredible presenters, because the feedback, the values, and then the, what would we say, like the feedback from the people, and then maybe providers or like the consumers, is important to strengthen the health policies. So it's not only the quantitative data, the evidence, but also the qualitative data. So the three of them are emphasizing those approaches to improve and strengthening the health policies. So we're moving to the discussions, maybe 3 questions first. Okay, sure. Then 2 and 3. Okay, first 3 questions.
My name is Paul Forster. I came here to Indonesia 10 years or so ago to do my PhD fieldwork. I'm still in Indonesia, now very largely working for the Stop TB partnership out of Geneva. Primarily I would like to respond to Rajendra's clear and inspiring presentation by providing some sort of counterpoint, in that I would like to say, in my humble opinion, it's all politics. I would say that the politics is unavoidable, and if I can take 2 minutes of your time, give 2 examples from Indonesia, and then as Madam Mboi is shaking her head at me, I would like to provide a political solution to one of Indonesia's biggest health problems. Going back 10, 11, 12 years, addressing avian influenza in Indonesia, there were intense political issues associated with all sorts of things, but primarily with how many people were dying of the H5N1 avian influenza in Indonesia. Secondly, how many cases amongst poultry there were. Now, influenza is a tremendously difficult disease. People don't die of influenza. People generally die of secondary bacterial infections such as pneumonia. The only way that you can actually determine whether somebody has died from influenza, particularly a specific strain of influenza, H5N1 as in Indonesia, H5N8, is through a polymerase chain reaction test, a very high level, molecular level test, of which in Indonesia 15 years ago there were 5 or 6 maximum PCR machines. So there was no way practically of knowing whether somebody in Tangerang or whether somebody in Sukabumi had actually died of influenza, let alone whether they died of this specific sort of influenza. And the number of cases in poultry, which were in the tens, if not hundreds of millions in Indonesia, it was up for discussion as to whether they had died of this particular disease or very many other poultry diseases. Sorry, to cut a long story short, in your triangle of evidence, nearly all of the information about H5N1 in Indonesia was at the very, very lowest level, was at the level of opinion. Right? More recently, regarding female genital mutilation in Indonesia. 4 years ago, I think, UNICEF put out a global study that was reported in The Guardian in London, it was reported in the New York Times, that said globally the number of cases of FGM had increased. If you unpack this a little bit, it increased because the amount of the number of cases of female genital mutilation in Indonesia had increased. So my wife and my wife's friends who read The Guardian and the New York Times came banging on my door and said, Paul, you're public health, what's going on here? This doesn't sound like the Indonesia we know. Bottom line is, when I got hold of the Ministry of Health paper that UNICEF had drawn the Indonesian data from, then I looked at the questionnaire that this data had been drawn from. Very largely it was the male head of the household who was being asked in order, what's your religion? Muslim. Are your boys circumcised? Yes. Are your girls circumcised? Yes. And that was it. There was no secondary data from female birth attendants or anything like that. So again, I would say there was a political answer to what should have been a purely technical question. Now, so I've gone on for a very long time. Madam, in terms of the problems with smoking and pulmonary diseases in Indonesia, the solution basically is to increase by 5 or 10 times the price of cigarettes. Globally, there is evidence that this basically is the only way you stop people like me and very many other people by smoking is just making it too expensive to smoke. But is that a politically acceptable solution for Indonesia? If a president or a health minister proposes that, what are their chances of being popular amongst the population? So I ask that just rhetorically, but my question is that in nearly all areas of public health, and particularly my passion in public health, are the political and social aspects. Thank you very, very much.
The method that you must do to obtain the data. So it's a brief introduction of the data. It's individual data, 1.7 million of our members, and we look forward for your policy recommendation from our data.
So we can access the data?
Yes.
Okay, so how can we access the data? So register to the...
Just log on to our website, www.bpjs-kesehatan.go.id. Then look for the right corner, upper right corner, and then it's PPID. Then you can click, and then there are some...
Okay, I'm sorry, I couldn't...
Just log on to www.bpjs-kesehatan.go.id and look for option of PPID. Then you can download the integrity pact that you must sign, and you must also obtain some documents, your research proposal, that those kind of things.
Okay, so we can provide it in like right away, or
yes,
we need to wait?
Provide it in 7 days.
7 days?
Yes.
Okay. If the proposal approved? No?
Usually it's approved.
It's approved, okay.
The data is available, so you can just use it.
Okay, so it's very useful information. Thank you very much. Wait. Okay. Okay.
Can you tell us, do you use the data yourself?
No.
Why not?
Well, because we have shared it with everybody.
No, I mean, we are talking about, I'm Unika Atma from Faculty of Law of Atma Jaya. I'm very much interested in the subject, and the idea in this seminar is that our health system should use the data to work, correct? And one of the most important institutions in Indonesia today is your organization. Do you really use the data in dealing with the yes? And how do you do that? Can you tell us more about that? Thank you.
Oh, thank you. Well, so the question is, do we use the data or not? So we use.
What kind of data and how do you collect data?
the data consists of, we have several databases. The first database is the membership database. The second one is the premium or the contribution database. And the third one is the healthcare database. So we use that this combination of three databases to come up with policy recommendations. So the nearest example is perhaps a couple of months ago we have launched also a Pradir Jampal Kasi. Are you familiar with that? Well, our internal regulation that tries to manage healthcare utilization, which is cancelled by the Constitutional Court. But again, all of those policy recommendations were based on our data. So based on the data analysis using our own data. So that's just to try to give you some broad explanation about how we use the data for policy recommendation.
Thank you very much, wonderful. So we're moving this third question.
Good afternoon. My name is Sheila. I am a pediatric resident from Cipta Mangunkusumo Hospital. So there are some comments that I would like, and there are some questions also that I would like to ask. So the first thing that we talk about data, I think we all praise how we use the data, but I think we need to see it from the other perspective also, that data is like a prisoner. So if you can torture the data, so it can say anything that you want. So I think it's very important how we give the data. I mean, how and who can access the data, because data is like, you know, it can speak anything. It's according to you, the one who analyzed the data. So you can say it will benefit you in a way, so you can analyze it, so it can help your perspective or opinion. Okay, and then I think there are some questions that I would like, and also perhaps some suggestion that I think Dr. Rajendra mentioned, that almost if we want to increase the access, that it means that we will need a higher cost that we have to pay. But I think that's where the technology can help us. So I mean, if you want to increase the access of, let's say, radiology examination, we don't have a lot of radiology doctor, but if we let the data be sent to a radiology doctor that is not in that area, perhaps it will help us to increase the access, and we don't need to have another radiologist there, perhaps. And then the second thing, I think we all know that the policy from all of the government, or many, many the policy that was made public was speak differently from the to prioritize health. I mean, we all want the government to prioritize health, but it seems like the government seems to speak in different language. They speak in currency language. So if we want to attract the government, we need to like change how the health, this approach could help them to increase the finance source, to increase their profits and in coming from the government. So I think perhaps if it's possible, how if we move the approach from the policy now that is health for all, which is to give access for everyone, what if we extend this approach into all for health, which means that perhaps in every department of, maybe in department of, any department that belong in a country, that should need someone that is the one who take care of the health policy. It means that if, in example, in the department of, in the department, beside the Department of Health, we have a lot of departments. I mean, like in finance, do we have a health people there? No, we don't have it. That's why most of our policy is probably will never prioritize health. And how can we integrate this thing from the data into the policy and to transform it into transformation that really happened to the society? Because I think the major problem is not to use the data to make a health policy that prioritize the health, but it is always how we transform from the policy into the real action. from the community. Thank you very much.
So maybe you want to comment or answering the question first?
Okay, I'm going to go with this question first. I think with respect to what you're seeing with respect to radiology, I think it has already been shown that is the best way in terms of you can improve the radiology access. Right now, most of the radiology, what you call evaluations are done on a remote basis. You know, it has already shown that it is effective, it can improve patient care, and it improve access. So that is one of the quality evidence which we already have. So anything which works, I think it can be easily improved kind of thing, even from the remote area. So I think that is a really valuable suggestion which can be easily implemented. The other thing which you have said with respect to, the thing is I'm not very aware of the community level decision making kind of a thing, but I think based on what I'm hearing from you is that right now I think it is not only that the health policy has to be done at a national, at a regional level kind of a thing, it has to be done at much more community and a local level kind of thing. So that requires lot of training in terms of manpower so that they understand in terms of how to prioritize, how to work on those kind of issues. So that requires a lot of education. So I think, that's maybe, I think it doesn't matter whether it's a government or educational institution. I think we need to put an effort, and I think I want to start with that education, especially for the physicians who are going to some of the rural level to understand what are the health policy decisions which they can contribute, because they have the training, now they need to understand the policy issues, ramifications. And I think we need to start with those, or maybe there will be the other community health leaders who are available. But I think you are right. I think it has to happen at a lower level rather than much at a higher level.
I'm just going to add something on the technology side. Remote sensing or use of technology to benefit those who are in remote areas is, of course, one of the main attractions behind pushing e-technologies and e-health. But at least in Indonesia, one of the issues is that the remote areas that would be most in need of it don't necessarily have the telecommunications infrastructure to support that type of system and setup. And so before pushing it too far, there would need to be a little bit of an ethical or more of a broader perspective look at the issue, because otherwise there's a risk of increasing the digital divide and excluding those who are most at need of those technological innovations. It's supposed to be an inclusive system, an inclusive setup, but because of the realities on the ground, if we go too fast and we don't take a stop and take a look at the actual people involved, then we run a risk of making the inequalities and the disparities worse.
What about the data from the government? In this era, I think the one who owns data is the one who owns the world, right? Mm. So every time we give something from ourselves, how do we know that it will be safe and it will only be used for our beneficial? I mean, what if some people that should not see the data see this data, like you say, the advertisement company or the insurance company? What if this data is not safe enough that we give up from them? Yeah.
The only thing which I am going to comment about is that US example. Most of the healthcare data is owned by the patient, that they have to get the release. So with respect to nationalized healthcare, the government who's collecting the data, they have the ultimate responsibility. I think the data which is being shared at right now on a subsample level of $1.9 million, it's a de-identified data. So I think, so de-identified data has a value with respect to research, but I think, it is not really linked to a patient per se. So I think there are ways which you can achieve technological achievement in order to make sure that it's not directly linked to one patient, but it can be done effectively. With the use of technology, I think there are more. But I think one thing I wanted to make sure that I think it is very, very important that we understand that the patient has the ultimate power with respect to how his or her data is being used. I think we need to have more regulations in terms of, it doesn't matter whether it is collected by the applications or something like that. in terms of how it is. I think the government has a little bit more say, because I think because it is going to be monetized. I'm pretty sure healthcare data is going to be very important in terms of what we do in the future.
Maybe I will add something. Sheila, I understand what your concern. You mean that the data, you can torture the data so the result, it will be appropriate or like suitable for the one who use it, right? That's what you mean, right? But I think the openness, like the validation of the methods, is important. You need to open how to do it, like how to analyze, how to how can I say that, summarize that informations. That needs to be open, so we other people can validate the external validation for the data. So that's the other solution for I think the published data or something like that. So the data cannot be used as please for the people that maybe, I don't know, they have something or they have how can I say that, like well, yang punya kepentingan gitu maksudnya. It's something important. Is that answering your questions? Okay. So maybe because, okay. Ibu Nafsiah.
Thank you. There were some questions that Mr. Foster, I'm the first one to recognize that political considerations are a big considerations, but I do not agree with you that it is just politics. First of all, as I said, it's also technical, political, social, economical considerations. And depending on where you are, of course, the higher you are, the more you have to consider more of those considerations, those aspects. And I can tell you, there's sometimes blood on the floor to discuss all that. Like your example about smoking. I was Minister of Health when I pushed for FCTC, and some yes say yes, some not. But and then I come back to you. Government is not homogeneous. The Minister of Health may think health is important. Minister of Trade says, no way, that's not my priority. And Minister of Industry or Minister of the other industries or pertanian, agriculture. You see, even for people, if you ask people, you're a doctor, is health your priority? For yourself, personal priority? Most probably not. So, so you have to consider it in that way. And indeed, we have tried, of course, to explain that health not only influences health, but health will influence the productivity, will influence the human resources. And that is why in RPJM 2020-24, as you can see, it is now integrated within the human development, which means health is a very important issue, equally important with education. For some people, education is even more important, and all that whole list I gave to you. Okay, so indeed, policy, as I fully agree with you, especially in development policy, is incremental. You learn every 5 years. We learn from our mistakes and our successes. Last 5 years, or last year, or last month, or last week, and then formulate whatever we can formulate. And I agree with, for instance, your question about BPJS. BPJS, since the beginning, has tried to actually institute a complaint method within their system. If you open your handphone and you are that apps, BPJS apps, you see that there is complaint. And BPJS, they have to reply within 24 hours for some, or maximum 1 week. Yeah, Pachitraya. Yes. Yeah. So they are evaluated on that. But don't forget, di atas surga, masih ada surga. Because if you ask BPJS, they may not be able to give the answer because it's not their authority. It's the wewenang, the authority of the hospital, for instance. For instance, patients complain about waiting time, long waiting time. They complain to BPJS, but BPJS cannot change that because it's the FASKES, Fasilitas Kesehatan, that have to change that. And I've just been going to several hospitals and institutions, and indeed some have indeed tried to improve the waiting time by instituting, for instance, online registration and all that, but not all. We are too big. Indonesia is so big. We have to have patience. Okay, so I think that, and Pa Foster, Pa Paul, actually, as Minister of Health, I've already proposed that harga rokok, the would at least be 100,000 rupiah. But of course, again, economical consideration, revenue, political consideration, social consideration. Because if you ask DPR, they say, go fly kite, okay? And DPR is not always only political, it's also economical. And they think they are representing their constituents, okay? So indeed, it's complicated. I agree with it.
Okay, so give an applause to the three presenters. We're at the end of the discussion. We apologize for all the audience that has maybe questions, but after this you can ask them personally. And we're moving to give souvenirs to the presenters. I guess.